All right, so we're going to finish this up with endotracheal intubation in EMS. A lot of controversy on whether or not paramedics should be intubating at all. What's the role of RSI? What's the role of DSI? What's the role of DAI? What's the role of KSI? So hopefully this will shed some light on it and it'll walk away with some pearls on best practices for intubation. So on slide 2, the objectives, really I'm looking for you to understand what the difference between RSI, DSI, and a crash airway is, and then when to use RSI, DSI, and a crash airway, and then understand the safety checklist and how to effectively and safely intubate somebody in 5 minutes or less using my handy dandy checklist. So RSI, slide 3. Rapid sequence intubation does not refer to the speed that you put the tube in the throat, okay? About 95% of the patients that you're going to RSI can be successfully managed with bag valve mask ventilation. Recall, we have been bagging people since Jesus Christ was a corporal in the Marine Corps. So we do not need to rush this procedure. Rapid refers to how fast and in what sequence we give medications. Rapid refers to induction or a sedative, followed by a paralytic, followed by an intubation attempt with no positive pressure, i.e. no bagging, no attempts at bagging in between. That being said, the patient needs to be semi-stable before we try and do this. The patient needs to have reasonable blood pressure, reasonable heart rate, and reasonable oxygen saturation and end-tidal CO2 in order to prevent or be rewarded with the post-intubation cardiac arrest. I think that if you follow the rules that I'm going to give you here, you're going to have a much better outcome, much greater, higher first pass success rate, and far less post-cardiac arrest events or post-intubation cardiac arrest events than you would potentially previously. RSI is largely prescribed for times when we think that there's a big volume of McDonald's just sitting in that stomach waiting to come up and meet you in the face as you stick the tube in the throat, or even more likely as soon as you bag the patient. So RSI is designed to prevent aspiration. In our risk matrix, our perceived risk and accepted risk is largely aspiration, followed by desaturation, and then lastly cardiovascular collapse. So cardiovascular collapse being in yellow, aspiration being in red, we're most worried about the patient aspirating, and the patient is relatively resuscitated and can hold their own for the brief period of time that we have to actually take their airway reflexes away with a paralytic. So on slide 5, success is predicated by 2 factors. Number 1, preparation. Everything in life, if you're more prepared for it, you're much more likely to be more successful. Positioning. If you can get the positioning right in the patient, your first pass success will almost always be successful. It's anticipating the complications and sidestepping the landmines where people end up not successfully intubating the patient because they fail to account for some of those things, and we'll talk about that in a second. I'm going to say it over and over again. Your first look will always be your best look because you're primed. Your mindset is right. Your tools are right. You have been intubating before. You know which blade you like to use. You know what size blade you like to use. You know which tube you like to use. You know which angle you like to use. So when you stick the blade into the throat and you are rewarded with a beautiful grade 1 view of the epiglottis and the cords, and you can pass that tube first shot, it builds your confidence. When you get lost in there and all you see is soft palate or tongue, even if you have been doing this for a long time, there's an element of panic that creeps up. And now you have to talk yourself down from that. So if you position the patient correctly and you prepare yourself and you anticipate some of the landmines that are coming, you'll be much better able to intubate these folks. What's the position we're talking about here? So the external auditory canal, the little hole outside your ear around the tissue, actually what we call the ear, needs to be lined up with the sternal notch. So when the patient is lying supine, that little hole of your ear needs to be lined up with the sternal notch or the angle of Louis. It needs to be a straight parallel line. If that line is not parallel, if it's off by a couple of degrees, you're not going to be able to line up the axes, and I'll talk more about that in detail in a second. Also, we need to elevate the head of the bed to 30 degrees. This does two things, actually does three things. So number one, it decreases intracranial pressure, and a good number of our patients that we are intubating, we're worried about their intracranial pressure. It decreases the risk of aspiration. By lying people flat, you're going to get silent aspiration because everything is in a parallel plane, and the McDonald's that is just lurking down there is going to start creeping up into the esophagus, and eventually will make its way into the glottis if you let it. Also, it's going to improve your view by bringing the patient's axes in line, and I'll show you that when we go through some of the schematics here. Indications for rapid sequence intubation and EMS. So either we have a failure to oxygenate, we have a failure to ventilate, either we're not getting enough oxygen in, we're not getting enough carbon dioxide out, we have a failure to protect the airway, the head injury, the burn patient, the anaphylaxis patient, or we have impending collapse. The burn patient, the anaphylaxis patient, the guy shot in the neck with an expanding hematoma. These would all be acceptable reasons that you would take somebody's airway in the field in order to prevent undue and unnecessary morbidity and mortality from an airway death. Okay, preparation and rapid sequence intubation, and for that matter, any intubation. If you follow this checklist, if you use it, then I guarantee you, you will never be looking for something. You will always be looking at something that you need. Why use a checklist? Because professionals use checklists, right? Pilots, before they get in that aircraft, they do a pre-flight checklist. And they have maybe been flying for 50 years, but they do it the same way every time so they don't miss something. And that's because when they get up in the air, it's too late to determine that we're missing something or something's not working, and now we have a catastrophe. We're trying to avoid the catastrophe by using a checklist that's prescribed. If BB blessed P doesn't work for you, then you can make your own checklist as long as you have some type of memory mnemonic that triggers what the gear you need and what the sequence of events you need to complete this procedure in, then it works. So B, bag valve mask. We have been using bag valve masks in EMS, again, for forever. There's one technique that you need to be intimately familiar with on saving somebody's life, and that's a BVM. Anytime we're talking about intubating somebody, we need to have a backup plan. We need to have a rescue airway. So BIAD or backup airway and BVM constitute the two and what we call the cardinal Bs. Our other friend in EMS for airway management is the bougie. I still call it the gum elastic bougie. I can't get it out of my head. It's no longer made out of gum elastic. It's made out of plastic. But the bougie is a great tool when properly deployed. It allows you to control a very difficult or invasive airway with a much smaller tube rather than trying to negotiate the big ET tube. Obviously, the laryngoscope. Mac or Miller. Most people have greater success with a Mac, but if you are a Miller person, great. However, in this day and age, I would argue that the vast majority of your intubations need to be video laryngoscopy or VL. I think DL still has a role, but we are finding that the greatest success in EMS and in emergency medicine, for that matter, comes with VL. If you take the difficult airway course, the instructors will all tell you that they have not done DLs in years. They work in really privileged hospitals that have VLs on the wall in every room in their resuscitation bay, and they just do video laryngoscopy all day with great success. End-tidal CO2, and for that matter, monitors. All the monitors need to be on the patient before we intubate. We need to have them set to run, and obviously don't put the blood pressure cuff on the same side as the IV that you're going to use, because that's going to complicate your ability to induce or paralyze the patient. I've done that before. That's speaking from experience. There's 3 S's. Suction, and you use the Ducanto suction catheter, which is awesome. You can suck up a small child in that thing. A stylet. You want a satin slip stylet, because you want it to be able to move quickly and smoothly through the ET tube. You don't want it to get hung up on the side of the plastic. And then a 10 ml syringe. Of that 10 mLs, you don't need 10 mLs of air. You need about 7. So do not fill this thing up like a Macy's balloon on Thanksgiving. Just fill it up with about 5 to 7 mLs. Your pilot balloon, that little balloon that sits that comes off the tube there, that confirms that your balloon is up at the distal end, needs to be pliable and should yield to gentle pressure. You should not squeeze that thing like you're popping a zit in your Dr. Pimple Popper. Endotracheal tube plus one size smaller. So for the average adult male, there'll be about a 7.5 to 8. For the average adult female, there'll be about a 7 to a 7.5. That means if you're intubating a male and they're relatively normal, you should pick a 7.5 or 8.0 tube and have a 7 tube ready to go. If you're intubating a female, you should pick a 7.0 tube and then probably have a 6.5 tube as a backup ready to go. Drugs, in this order: sedative, paralytic, and post-intubation sedation. So before you tube the patient, pull up the post-intubation sedation because you're going to forget. Every time somebody drops the tube, there's a high five moment with the whole crew, and then the patient starts bucking because nobody remembered to give the patient the Versed or the ketamine after we intubated the patient. And now the patient is totally alert and aware of what's going on and has a piece of plastic between their cords. That's a party foul. That's points that are deducted for style. So draw them up before. Label your stuff, okay? Label the sedative, label the paralytic. If you're not going to label anything else, label the one that will kill the patient, the paralytic, okay? Nobody's going to die from a dose of ketamine. I promise you that. They will die from a dose of succinylcholine or rocuronium that gets pushed erroneously. Moving on to the right side of this slide, slide 7, the P's. So preparation. This is where BB Blessed P comes in. Getting all this stuff arranged and you're looking at it and prepared to use it is going to save you a lot of mental energy in preparation, in actually completing this procedure. The next thing you want to do is throw some passive oxygenation on the patient. This is a nasal cannula, and I've heard people cite 15 liters a minute. That's not enough. You need to turn this thing up till the valve stops. Ideally, you're in the ambulance. This is the main O2, and you turn the valve all the way to the right until it can no longer go, and you can hear it. When I intubate patients, and the corpsman asks me what I want the oxygen set at, I just tell them I want to be able to hear it from the doctor's station. And when I hear the hissing, I know the patient's getting enough oxygen. The whole idea for this thing is to overcome airway resistance by collapsed airways at the top of the glottis, right? So this is most beneficial for patients who have a lot of subcutaneous fat, who have very proud tonsils, who have large adenoids. We're trying to literally blow air past that tissue, and in order to do that, you need pressure. The pressure comes from the volume. Crank the volume up. Positioning. Recall what I said about the external auditory canal being in a parallel line with the sternal notch and the head being at 30 degrees. If you put the patient in that position, you're more likely to have a first pass success. Now we're in it to win it. So we're paralysis with induction. Induction comes before paralysis. Sedative and then paralysis. Salt and pepper. So pick your sedative agent, whether it's going to be ketamine or etomidate. Pick your paralytic, whether that's going to be rocuronium or succinylcholine, and push those two drugs when everything else is ready. As soon as those drugs are pushed, you wait for the patient to achieve paralysis, and then you place the tube. An ET intubation attempt is defined as the blade goes past the incisors. So as soon as you stick the blade in the mouth, that's an attempt. Once we've intubated the patient, we need positive confirmation. You guys need 2 forms of positive confirmation in order to say that that tube is where it's supposed to be. The best and most universally accepted is end-tidal CO2 with a graph readout. So we're looking for the mesa, right? We're looking for the plateau, followed by the drop-off, followed by the sharp incursion, followed by the plateau. That's great. You can still get that with the tube in the back of the throat. I've seen it happen where the tube was not in the trachea. It was just butted up, juxtaposed against the trachea, and I had a beautiful end-tidal CO2 readout. You need misting and fogging in the tube. You need condensation in the tube. You need breath sounds present on both sides, or you need to make sure that you didn't go too deep and drop a right mainstem intubation. You need absence of breath sounds or absence of air over the epigastric area. And ideally, you should be able to have a recorded video laryngoscopy view showing that that tube successfully negotiated the cords. As a style point, how do you know when to stop advancing the tube and prevent a right mainstem intubation? So some of the tubes have a black line at the bottom of the tube just north of that cuff. That black line is designed to be visible at the level of the cords. So if you line up that black line with the cords, That balloon is exactly where it's supposed to be, and that tube, the tip of the ET tube, will be 2 to 3 centimeters from the carina, from the branch point of the lungs. Lastly, post-intubation management, and this comes into either troubleshooting why the patient is difficult to bag, or sedating the patient for the transport and anticipating the transition to the emergency department. This is a video or a visual representation for those of you who are visual learners about all the stuff that you need at minimum to do this. A bag valve mask, bougie, biad, laryngoscope, suction, stylet, and in that stylet is the ET tubes, syringe, end-tidal CO2 with monitors, and then the drugs. And then if you see, I'm sure you've all seen the end-tidal CO2, but that's what I was talking about. Sharp incursion or sharp upslope, followed by the plateau, followed by a sharp deceleration and drop-off. You don't want the shark fin. Shark fin is indicative of people who are stacking breaths, who have auto PEEP, and those are going to cause you problems during that transport. The patient's going to become either hypoxic or hypotensive. Okay, here is the positioning that we were talking about. This is slide 9. So this is a relatively normal body habitus male, and you can see that his external auditory canal, that little hole on the inside of his ear, is lined up perfectly parallel to the deck with that sternal notch. What we're trying to do is orient 3 axes that are required for intubation. The right side shows you what wrong looks like. So there is nothing behind that gentleman's head in the top picture, and you can see that his external auditory canal is below the sternal notch. This is going to make that intubation attempt significantly harder. By elevating it with some blankets, we're bringing that external auditory canal in line and parallel with the sternal notch, and it's going to align all 3 axes that you need to intubate the patient. This is slide 10. This is a pediatric intubation, and they're even more difficult because they're giant heads on small bodies, so the axes are even more pronounced. But the same point with holds. We're trying to line up the oral axis, the pharyngeal axis, and the tracheal axis. And by elevating the back of the head and lining up the external auditory canal with the sternal notch, those 3 angles should achieve near union, and we should be less than 30 degrees. And slide where image B shows you what right looks like, and the ability to view those chords on the single intubation attempt with the axes lined up. Now I know what you're thinking. What about trauma patients? This kid's head's relatively extended. Take a look at these patients here. These patients are largely in the neutral position. They're not hyperextended. So this is still accomplishable for patients who have C-spine immobilization. All right, moving on to slide 11. So which induction agent should I use? Well, based on our protocols, we have 2 options, ketamine and etomidate. They both have charms, and they both have relative issues with giving them. Ketamine is probably as close to an ideal induction agent in emergency medicine. It falls into the category of dissociative anesthetic. Now, when you give ketamine to the vast majority of patients, you're going to be rewarded with a heart rate and blood pressure increase, which is usually good for the patients that we're trying to intubate, because they usually have oftentimes a high heart rate already, but they have a low blood pressure, or the patient has a low heart rate because they have a cardiac problem. It also is a pretty potent bronchodilator, and it causes secretion of mucus, so it's a mucociliary agent. But probably most important is it's a neuroprotective agent. It increases the delivery of oxygen to injured cerebral tissue, or what's called the DO2. And by blocking an excitatory neurotransmitter called MDMA, it will help with some seizure prevention. So really, there's not a lot that ketamine doesn't do for the vast majority of the patients that we take care of. Now, etomidate still has a role. It's cardiac neutral-ish. You can get a little bit of hypotension with it, but that's usually pretty rare. But what's concerning, though, is it causes myoclonus. So when you give it to folks, they're going to start shaking. That is not fasciculations. That is actually like muscles actually contracting. And that can raise your ICP. So we usually avoid etomidate in folks who have ICP problems. It's a mild bronchodilator, but not nearly on the same level as ketamine. And there's always a question of whether it causes adrenal suppression. This has been debated since I was a resident. People still don't have a great answer on whether or not It causes adrenal suppression, and the fear is that if we give it to septic patients who are already adrenally insufficient, then we're going to make their hypotension worse and potentially increase their morbidity and maybe even their mortality. So, who gets what in EMS? Major trauma, isolated head trauma, status epilepticus, asthma, sepsis, metabolic disorders, or respiratory problems, and then one cardiac problem, pulmonary embolism, should all get ketamine. Simply stated, when you want to increase the pressure and the body or the heart can tolerate an increase in blood pressure and heart rate, ketamine's your agent. Patients who are in cardiogenic shock, have a hemorrhagic stroke, who are eclamptic, who have acute decompensated heart failure or have an aortic dissection, patients who cannot tolerate rapid increases in heart rate and blood pressure should probably get etomidate. So when the increased blood pressure and myocardial oxygen demand places the patient at considerable risk, I would choose etomidate. How about the paralytic? Does the paralytic in EMS matter? Well, yes, it does. So rocuronium, largely great for head trauma patients, for chronic renal failure, and any neuromuscular disorder patient. We're talking about patients who had prior strokes, who have a spinal cord injury, who have a form of muscular dystrophy, or who have a rheumatologic disease like Eaton-Lambert syndrome, which comes with cancer, or myasthenia gravis. Also, patients who have a crush injury and major burn. The thing that we're really worried about here is the hyperkalemia that comes with succinylcholine. Now, the major burn patient is usually 1 to 5 days post-burn. The potassium receptors don't get upregulated immediately with a burn. It takes a couple of days for that to actually happen. The bad thing about rocuronium is if you miss, the patient's paralyzed now for about 30 to 60 minutes. So you could take somebody who has a difficult airway, find out you have a failed airway, and now the patient has no airway reflexes, and that is largely irrecoverable in EMS. Succinylcholine, does it still have an indication? Yeah. So I use Sux when I need the patient intubated now, and I cannot wait for ROC. I have used ROC for a while. I've used Sux for a while as well. Sux is very predictive. 45 seconds, that patient is paralyzed and ready to go. I need to have reasonable success that I'm going to be able to accomplish this tube, i.e. the patient may still be a difficult airway, but I have figured out my plan, and I can successfully negotiate that plan, and I have got a plan for a backup and a backup. So we're already down the road of ET, intubation, BIAD, and lastly, crike if this goes into a failed airway. The good thing is, if I do miss, I have a patient who is not breathing for 6 minutes, and as long as I can bag that patient, I can largely get myself out of trouble most of the time. So, who do I prescribe succinylcholine for? Patients with a predicted difficult airway. Notice that I say predicted, not a failed airway. Tenuous vital signs prior to induction, i.e. somebody who needs oxygen now, who is failing bag valve mask therapy, and I would largely question whether or not it's safe to intubate that patient in the EMS setting with poor lighting, poor positioning, and relative lack of resources. You're probably better off putting a BIAD in that patient and transporting them to a hospital who has an OR where the patient can get a surgeon and an anesthesiologist who can secure that airway much more safely. And then patients who have poor cardiopulmonary reserve, i.e. patients who will not tolerate hypoxia. For the vast majority of healthy patients, if we were to pre-oxygenate you for elective surgery and we were to put oxygen on you at high pressures and use a PEEP valve, you could have a pre-oxygen or a apneic period where you were not breathing of about 8 minutes before you desaturated below 90. Some of our patients have a apneic period of 30 to 60 seconds. That means one look. This is why this is so important. So, RSI drug combinations by diagnosis, major trauma. I'll give you guys a chance to think about what you would use, but my prescription for major trauma is rocuronium and ketamine. And this largely comes down to the idea that I want to protect the patient, and there's always that risk of hyperkalemia with crush injury or with massive fluid shifts, so I prescribe rocuronium. What about coma and hypertension? Actually, hopefully, septic shock, I use ketamine and succinylcholine. The Sux I prescribe because that patient usually has an oxygen deficit, and if the patient can tolerate hypoxia or a prolonged apneic time, then I will use ROC. But if the patient needs an airway, with pneumonia being the most common reason that people end up septic in the United States, I usually need that patient intubated quickly. Coma and hypertension. This is the indication for etomidate. So we've got patients who very well may have an increase in intracranial pressure. This may be isolated head trauma. This may be more likely stroke, hemorrhagic stroke. And we don't want to raise the blood pressure in stroke, right? But we also don't want to raise the ICP. So this is a trade-off. The etomidate is largely going to be safer because the fasciculation or the myoclonus is not going to be as dramatic as the blood pressure swing that's going to come from the ketamine. This is asking the practitioner to use or to pick the better of two evils, and in this stage it's probably etomidate and rock. What about coma and an MI, or a coma and unclassified shock? And this is a patient who probably could either get one or the other. I picked etomidate and succinylcholine because you'd have to figure out what the source of this person's problem is. But the idea that I'm trying to hit at here is if the patient has cardiogenic pathology and the heart has already taken a flogging, you don't want to flog it even more with ketamine. So etomidate and sucks for the rapid onset and the rapid off is probably your best bet. This is all debatable. This is largely my opinion. Everybody's got an opinion. So certainly not gospel, but a place to start nonetheless. All right, the P's of intubation. So preparation, this is your BB blessed. This is done about 5 minutes prior to your intubation as you're getting the patient prepared for the tube. So one paramedic needs to be prepping the patient. That means pre-oxygenation, positioning, oral airways or nasal pharyngeal airways, and really getting that patient designed so that they have the best first chance success. The intubator, the person who's actually going to be placing the tube, should do their own checklist. They should assemble their own gear. Everybody wants to be a friend and help out, but if I'm doing the procedure, I need to have positive control over the stuff that I'm going to use because I need to know A, where it is, and B, that it's there. In about 5 minutes, your partner should also be giving you some passive oxygenation via high flow nasal cannula. And if you're going to use a bag valve mask, make sure you put a PEEP valve on it so that you actually do get some treatment effect as opposed to just ventilating the patient. Because again, what we're trying to do is denitrogenate the patient. We're not actually hyperoxygenating. We're removing the nitrogen out of the patient's lungs and replacing it with 100% oxygen so that we have an oxygen reservoir. We're also, if there's a role for pretreatment, this is the time to give it. So we don't have lidocaine on the truck anymore, but we still have fentanyl. And for patients who have head injury, 0.3 milligrams per kilo of fentanyl is reasonable to decrease the sympathetic tone and in theory, decrease the rise in ICP. In about 3 minutes, you want to start positioning the patient and really focusing on your pre-oxygenation. And this is the time where you're allowed to ventilate the patient. Now, an adult ambu bag, an adult BVM, is a liter. If I was to blow a liter into you, you could probably tolerate that for about 5 or 6 breaths, and then you'd say, no more, I can't take it, that's too much volume. So we can certainly induce barotrauma, but more importantly, remember that McDonald's that was sitting in the stomach? If you blow a liter to somebody, that McDonald's will come up. Bagging faster and bagging harder does not make the oxygen saturation come up any faster. So there's no reason, again, to fill this patient up. I don't know if you guys remember the resuscitator. When I came into EMS, the resuscitator was big, and it was a pressure valve that the cops had on an oxygen tank. And by the time you got to the patient, there was vomit everywhere because the cops knew how to do one thing, and that was throw the resuscitator on and then fill the patient's esophagus up with plenty of air till they vomited. Made my job a whole lot more fun and hard. That being said, you need to squeeze the bag gently at a rate of about once every 6 seconds. And again, the position of the airway is the most important thing. You need to overcome the resistance of the tongue, so you need to have some type of an external airway in there, whether it be an OPA or an NPA. If the patient won't tolerate an OPA, maybe we need to ask, does the patient need to be intubated? All right, now we're at T-0. This is induction and paralysis. And we're quickly bang, bang. So we're pushing ketamine, we're pushing the etomidate, followed by the paralytic. And then we're waiting if we're going to get fasciculations with succinylcholine. We're waiting for the fasciculations to stop. If we're using rocuronium, we're not going to get fasciculations. It's not going to happen. The medicine doesn't work like that. But we're waiting until we get a flaccid jaw, and then we're inserting the blade, whether that be a VL, preferably, or a DL, and locating the epiglottis, which is again locating the cords. We're going to pass the tube and place the tube at the right location, again using that black line at the bottom of the ET tube if it exists. If it doesn't exist, you want to view the balloon going through the cords, advance about 1 to 2 centimeters more, and stop. We're going to inflate our pilot balloon, and we're going to get positive confirmation of the ET tube. The very first thing that goes on the patient is end tidal CO2, and we're going to look for that plateau end tidal CO2 readout. If we got a shark fin, we got a problem with what? Not oxygenation, but ventilation, and the patient is air trapping. That means we need to slow the rate down and provide deeper breaths. And then lastly, post-intubation management. And this is why we pull up the post-intubation drugs, because as soon as the patient gets intubated, we give them a big slug of something so they don't remember it. But more importantly, they comply with the therapy. They don't reach up and pull the tube out. If that hasn't happened to you yet, it's coming. Okay, some pearls. So, ramp your patients, especially obese patients. Patients who are obese have a deposition of fat behind their neck and across their shoulders, like in the area of the shoulder blade. This gives them a relatively hyperextended airway when lying flat. That's beneficial to you, but it's not enough to overcome the resistance of the excess tissue that sits on their chest. And more importantly, patients who are obese have a lot of subcutaneous adipose tissue sitting on the chest that causes a restrictive lung pattern. So you need to sit the patient up and ramp them up. They need to be more than 30 degrees. They probably be closer to 45 degrees in order to overcome all that resistance from the tissue that's just sitting on the chest. You're going to limit their respiratory excursion, their ability of their chest to move up and down if you keep them supine, so ramp them up. Anticipate the cardiovascular collapse after RSI. This is why the patient needs to be resuscitated before you get into the situation. You're going to induce positive pressure ventilation. Positive pressure decreases the preload. If they have hypotension, you're going to make it worse. So again, have your pressors ready. This is the time during your preparation to pull and prime that pump with norepinephrine and volume resuscitate the patient with LR so that they don't have a cardiovascular collapse, or at least you can try to prevent it as much as possible. Again, VL, not DL. VL is the way to go. And if you're not comfortable with it, I would suggest you spend more time getting comfortable with it, because that's the future of EMS. The fractional inspired concentration of oxygen matters. We're looking for SATs of 94%, not 100%. Okay, 100% hurts patients. 94% reasonable. So how do I do this? If the patient doesn't have an oxygen problem, if I'm intubating them for airway protective measures, i.e. they have a head injury, I'm looking to keep their FiO2 somewhere around 50%, right? So what this means is they don't need to have 25 liters rolling through the bag as you're ventilating the patient. It's totally acceptable to have them at 10 liters. If they're hypoxic and they need oxygen, then certainly you want to give them a high concentration of oxygen. But just because they're getting intubated does not mean everybody needs a high concentration of oxygen. The cuff pressure matters. As I said, the average adult needs about 5 to 7 mLs in the cuff, not 10. The reason this is important is because it takes about 15 minutes for the trachea to start dying, to get some necrosis on the inside of the trachea from that balloon. And if you take them to a hospital, if it's a good hospital, they're going to put a manometer on the tube, on the cuff, and measure the pressure, because they want to prevent that trachea from sloughing off and causing increased edema and creating more of an airway problem than already exists. I can't say it enough, folks. Positioning, positioning, positioning. If you walk away from nothing else from this topic or from this talk, remember external auditory canal, align with the sternal notch, ramp up obese patients, positioning. As long as you position the patient, your first pass success will be much higher. If an attempt fails, have somebody, not yourself, bag the patient, and then try something different. This is all strategy. So try a different blade, try a different position. If need be, try a different intubator. There is no shame in missing an airway. There is shame in killing the patient because we just kept repeating the same thing over and over and over again. We've all missed airways. I have missed airways. I've had to have anesthesia, two behind me. Yeah, it's a little bit of embarrassment, but again, it's not about us. It's about the patient. Take care of the patient. There's all kinds of reasons that people miss airways. Some of it comes down to just mental frustration and not being able to concentrate. This is an extremely difficult task that takes years to master, and has the potential to really hurt somebody. So we got to be smarter about this and work through the problem, and sometimes that just means getting a different technician in there to place the tube. Cardiovascular collapse after RSI. The dope mnemonic comes into play here. So this is somebody who starts to deset and may become hypotensive. First thing you want to do is check for a dislodged tube. Make sure the bag valve mask is still connected. If they're connected to a ventilator, you want to run the circuit. Make sure the circuit's connected. This is important because the obstructed tube, I always thought of an obstructed tube as something was actually physically within the tube, like a piece of goo or blood or, all that McDonald's I'm talking about. But a 6.0 or 6.5 ET tube can kink pretty easily with just movement of the neck. So it may mean that the patient needs a cervical collar, not because they have cervical pathology, but to keep that head in line and prevent the head from dropping to the side. I've had that happen to me a couple of times with a 6.5 tube where the patient's head slid to the right and all of a sudden the airway alarm went off on the ventilator because there was an obstructed tube. Pneumothorax is always a possibility, especially in patients who have chronic pulmonary disease like asthma or COPD. When we switch them to positive pressure ventilation, if we're bagging them too vigorously, we can cause some barotrauma and cause a pneumothorax by rupturing of blood. And then equipment failure. And largely this is probably going to be the minority because the equipment that we use is usually pretty reliable. Hypotension. The first thing you should think about is decreased preload. We went from a negative pressure environment to a positive pressure environment. We're now slamming that inferior vena cava shut. So we need to be given fluid boluses of LR. The next thing you need to think about, if that's not the source, is the intrathoracic pressure. And this comes from a spontaneous pneumothorax that then causes a tension physiology. This also can come from somebody who has COPD and has air trapping. So how are you going to know this? The bag's going to be really hard to squeeze. You're going to stick 2 needles in the chest. You're not going to get any air out. Now you have 2 pneumothoraces and the patient's still hard to ventilate. So if you take the bag off and you squeeze the chest, you're going to hear this god-awful sound like eeeeee. And that is all the air escaping that has been trapped in the patient's lungs. That's happened to me a couple of times as well. Going back to the preload real quick, how do you know if the patient is volume deficient at the bedside? What's an easy way to figure it out? Easy. You take a blood pressure, you record it. You have somebody lift the legs of the patient about 30 to 45 degrees, and you repeat the blood pressure. If the blood pressure goes up, the patient needs volume. If the blood pressure stays the same, then the patient's not going to respond to a fluid bolus. Giving them 2 or 3 liters is futile. They need something else. They need a pressor. There's already enough fluid on board. They're not going to respond. It's a very simple bedside test, and you can Google that or go on YouTube and check it out. But it's a passive leg raise as a predictor of preload and volume depletion. And then lastly, extrathoracic pressure, and this is the obese patients, somebody with 25 or 30 pounds of adipose tissue sitting on the chest. This is also sometimes seen in women with large breasts who when they're lying supine, large breasts will limit their chest excursion and make it much more difficult to ventilate the patient. What about low oxygen saturation after RSI? Again, number one, pneumothorax, especially in the patients with COPD or asthma from a ruptured blood. I talked about tube obstruction and kinking, specifically in the small diameter tubes like the 6.5 tubes. Equipment failure, so disconnected tubing or a dry bottle. Has anybody ever had the occasion where we've been so fixated on getting the intubation that we ran out of oxygen and didn't know it? It's actually not that uncommon. Other things you can think about are VQ mismatch, like a fixed obstruction. Pulmonary embolism is a classic example of this, where you got low oxygen saturation, the patient's intubated, you're still unable to ventilate that patient, you're still unable to oxygenate that patient. What do you do in the EMS situation? The patient needs ECMO. That's not available to us in the pre-hospital setting in the United States, at least in North Carolina. You need to transport that patient as quickly as possible to someplace with ECMO. Unfortunately, here that patient's unlikely to survive because the closest ECMO facility is in Greenville. Barotrauma or iatrogenic lung injury, that's up there with pneumothorax, but you can still get barotrauma without causing a pneumothorax, and this comes from overzealous bagging, trying to push all 1,000 milliliters that's in that bag through that patient's lungs. Lastly, it's a toxin on board. They may have methemoglobinemia, or they may have chlorine inhalation, or they may have something that's causing massive pulmonary edema that falls into a diffusion problem that causes low oxygen. There's not a whole lot you can do about that. The whole point of this tube is, number one, exclude pneumothorax, check your equipment in your tube, and if the patient's still not responding to that and everything is connected and working appropriately, then haul ass and get out of Dodge. I hot linked the MCRIT intubation patient shock. This is the part of the laryngoscope as a weapon series that Weingart did, and you can click this link, and David can share this this talk with you guys, and you can listen to Scott's version of how he takes care of patients who are peri-arrest and need to be intubated. Okay, delayed sequence intubation. So this is the use of a sedative without immediate paralytic agent for oral tracheal intubation. Notice it's immediate. So we talked about RSI, and that was bang, bang. Sedative followed by paralytic followed by tube. This is sedative followed by something else. And that may be another procedure, or that may be a look, like a video laryngoscopy look to see if we can see chords. This is part of the difficult airway algorithm to see how much trouble we're going to get in. Once we've located the chords, then we can push the paralytic, paralyze the patient so the chords approximate, and we can pass the tube. Don't try to pass the tube on a spontaneously breathing patient. It doesn't really work out that well. We did that for years with nasopharyngeal or nasotracheal intubation, and you can end up actually rupturing somebody's cords. That's a bad day. If you really had to, I suppose it would be acceptable. But ideally, if you've got a great look at the cords, have somebody push some rock or some sucks, and then take the airway. So this is also called drug-facilitated intubation or drug-assisted intubation. Ruben Strayer is a guy in New York City at Maimonides Medical Center, calls it ketamine sequence intubation. He has a page devoted entirely to why ketamine is the end-all be-all in emergency medicine. I agree with a lot of what he says, but the whole point here is that the indication the patient needs a definitive airway, and there's concern for either a difficult airway or difficult intubating conditions. It's prescribed for patients who brief hypoxemia associated with paralysis can precipitate cardiovascular collapse and cardiac arrest. So the patient needs resuscitation, but maybe they will not cooperate that. They have a behavioral emergency, or they're hypoxic and now they're combative and agitated, and we need to be able to ventilate the patient, but they're pushing the bag off or they're pushing the CPAP off, and you give them a dose of ketamine, which is an induction agent dose, and you bag the patient while you're prepping them to be intubated, but you're resuscitating them at the same time, whether that be with blood products or whether that be with fluid or whether that be with pressors. The idea is that you're getting their hemodynamic status more in line with an acceptable plane for intubation. The goal here is to be able to intubate the trachea without cessation of breathing or loss of airway reflexes until you're ready to push the paralytic. So on our risk matrix, desaturation is now higher than aspiration, and the cardiovascular collapse is a close second. So what are the pros of DSI? Well, number one, it helps people comply with pre-oxygenation and passive oxygenation or apneic oxygenation. It facilitates bagging or non-invasive positive pressure ventilation. It'll give you an idea what the patient's going to do by putting the CPAP on the patient. And if they tank as we're putting positive pressure in, then the intubation is not going to make anything better. In fact, it's going to make it worse. So they obviously need to be resuscitated. You may be able to get a second line or start blood products or give volume and pressors. Either way, the patient requires some resuscitative efforts, that the airway is not the immediate problem in this patient. There's something else. It allows the patient to retain their airway reflexes and spontaneous ventilation by not paralyzing them. But most importantly, it buys you time. It buys you time to get stuff done and, again, to resuscitate that patient. The cons is a lot of people will say this is suboptimal intubating conditions because you're not doing that bang-bang sedative followed by paralytic, that you have a decrease in the time. And if you do not paralyze the patient, you're not removing their glottic tissue tone, and that's going to interfere with your ability to intubate the patient. And there's always the potential drug side effects, particularly with ketamine, which is hypersalivation and laryngospasm, both which will complicate your ability to intubate the patient. And then lastly, as anything in airway management, we worry about aspiration. So DSI, the decision to use a paralytic is largely dependent on the intubating conditions. I keep saying this over and over again, but really it's just as simple as that. If it's a difficult airway, that may be a good candidate for a DSI patient, because you may get a free look at the airway before you fully commit with a paralytic, and now you are bagging this patient for 6 to 30 minutes. Obese patients, predicted difficult airway benefits, Predicted difficult airway patients may benefit from this because, again, we get a free look without actually committing. But you have to weigh the risk of aspiration of suboptimal conditions and post-intubation collapse from under-resuscitation with DAI. The minimum equipment and the checklist still pertain to DSI. So how do you make the difference between RSI and DSI? We have a bell-shaped curve, and you got to answer 3 questions. Does the patient have a high oxygen deficit? Does the patient have a high ventilation deficit? And does the patient have a perfusion deficit? So is the patient hypoxemic? Is the patient hypercarbic and acidotic? And is the patient in shock? And the patients in the green arrows on the outside of the bell curve are the patients you need to intubate now. So either the patient is so sick that if we were to wait to intubate the patient, they're going to get significantly worse. This is your anaphylaxis patient. This is potentially your airway burn patient, or your expanding hematoma. And most of the time, these patients fall into that stent category where they need an airway that is just stented open to allow the tissue to swell around it and not occlude the airway. You got to go now. So that's RSI, bang, bang. Then there's patients who have relatively stable vital signs, reasonable blood pressure, heart rate, and oxygen saturation, reasonable end-tidal CO2. Still need to be intubated. Most of the time, this is your stroke patient, your comatose patient, but they have the ability to wait for you to do the full preparation checklist, and this is your RSI patient. This is the mainstay of the patient that you're taking care of in EMS. Then there's the patient who needs to be resuscitated before you even think about giving them a paralytic. Once we give a paralytic, we're going to take away a lot of sympathetic tone. That sympathetic tone may be what's keeping them alive. If we take away tone in somebody who's already on the edge, you're going to push them straight over the edge, and they're going to have a bad outcome. So resuscitate these patients with high oxygen deficits, high ventilation deficits, and shock before you try and intubate them, unless they fall into that category of so sick that they can't wait. All right, what about induction and neuromuscular drug dosages? Etomidate, this is largely prescribed in the protocols. This matches pretty close to what we have, but 0.3 of etomidate, 2 milligrams of ketamine. We don't use propofol as induction agents here in this system. And then fentanyl, the most important point here is that the patient is in hemodynamic compromise. When you're going to give an opiate or benzo, you want to reduce by 50% the dose because there's going to be accumulation in the tissue, and then they're going to get a big slug of that stuff, and it's going to make your problem much worse. Sucks. I prescribe to the 1.5. I actually prescribe to the 2.0 dose. Gives me better intubating conditions. ROC is a dose of 1.2 milligrams per kilo, and we don't use VEC. The most important thing about ROC, 30 to 60 minutes, that patient no longer has airway reflexes. So you got to have relative confidence that you can get that tube before you push the ROC. This is a hot link to an article from Life in the Fast Lane on delayed sequence intubation. If you're interested, just click the link and you can read their article. I think it's a good job that they did. Crash airway. This is the unstable patient, requires airway now, and a lack of airway is going to lead to morbidity and mortality. Again, this is largely tracheal or neck pathology, such as a foreign body obstruction. This is a pretty rare event in the 21st century. Less than 1% of our patients, as most of our patients now get managed with either RSI or DSI. Same intubation checklist and the same equipment. You've all had a crash airway. If you haven't, it's coming. You'll know it when you see it. But you still have the time to get your gear ready, and the way you lay out your gear largely can accomplish this intubation checklist. I'm going to throw it up there one more time so that people see it. BB blessed, bag valve mask, backup, bougie, laryngoscope, end-tidal CO2, suction stylet syringe, endotracheal tube plus one size down, drugs, sedative, paralytic, and your post-intubation, and then your P's, preparation, pre-oxygenation and passive oxygenation, positioning, ramp the patient, towel under the head and shoulders, head of the bed at 30 degrees, EAC aligned with the sternal notch, paralysis with induction unless you're using DSI, placement of the endotracheal tube, positive confirmation via 2 forms, and post-intubation management with sedation, volume, and vasopressors if the patient remains unstable as far as the hypotension, and they are adequately volume resuscitated, i.e. they have a negative passive leg raise. They cannot tolerate any more volume with any more clinical benefit. Obese patients, their physiology, what's the most important thing? They have a decrease in function or functional vital capacity. So they have less oxygen space to work with in those lungs for all kinds of reasons, largely due to airway resistance and external weight on the chest. So they end up with this rapid, shallow breathing, and they end up with an increased work of breathing and increased oxygen consumption, meaning they need more oxygen than the average person does. This is all important because their increased neck circumference, that dorsocervical fat, the fat between the shoulder shoulder blades I was talking about, and the deposition on the trunk and the neck make your job a whole lot harder. The end result anatomically is they have smaller, more narrow, more restrictive airways, and they have a less ability to tolerate apnea. How do you overcome this? Ramp them. 45 degrees, ramp them up, put something behind them, hyperextend their airway unless they're a trauma patient or they have cervical pathology that you can't hyperextend them. It's going to give you your best look. What about the drugs for obese patients? Ideal body weight, rocuronium. Total body weight, etomidate, succinylcholine, and midazolam. That means if the patient's 300 kilos, you dose them on 300 kilos for etomidate, fentanyl, midazolam, and sux. Lean body mass, there's no way you guys are going to be able to figure out lean body mass for ketamine. Dose them on total body weight for ketamine. Ketamine has a ceiling effect, meaning they don't dissociate more if you give them 12 milligrams per kilo of ketamine than you do if giving them 2 milligrams of ketamine. Dissociative is dissociative. What ends up happening with higher doses of ketamine is they end up on a general anesthetic plane. Our dose of 2 milligrams per kilo is not going to hurt the patient, even if they're 300 kilos. It's going to take a lot more ketamine to get them down, but you're still dosing them appropriately. Okay, who's the patient that gets RSI? This is the relatively stable patient with need for definitive airway, acceptable vital signs, and no predicted cardiovascular decompensation during intubation. Who gets DSI? Patient with agitation, comorbid disease, or under resuscitation. Requires some resuscitation prior to intubation. These are also patients with poor cardiac or cardiovascular reserve, such as the elderly, the obese, and the comorbid disease, where a brief apneic period can cause collapse. Who gets a crash airway? The airway is the problem, and the source of hypoxemia or the cardiovascular instability, or the patient is so unstable, and the instability comes from a lack of oxygen or an excess of ventilation, and the patient is not effectively oxygenating or ventilating and needs to be intubated now. That's a crash airway. In summary, trauma patients, ketamine and rock; cardiac patients, etomidate and sux; respiratory patients, ketamine and ketamine and sux. Metabolic patients, you can pick either sedative and rock. Obese patients, you can pick largely ketamine or etomidate, doesn't really matter. Elderly patients, you're probably better off with etomidate given ketamine's tax on the heart. And then septic patients will probably benefit from ketamine. And you want to remember to ramp elderly, obese, metabolic, and respiratory patients because they're not going to be able to tolerate that apneic period as long as more healthy patients would. With that, I'm sorry I couldn't be here with you guys tonight, but I appreciate you listening to my lecture, and feel free to email or call with any questions related to this, and look forward to seeing you guys either in the ER, on the street, or in future Con Ed sessions. Thanks again.